Now we're going to see what we need to evaluate during the initial visit of a pregnant woman. So what we need to evaluate is basically 5 things, which is diagnose is indeed the patient is pregnant, so we need to do the diagnosis of pregnancy. Then we want to know the dating. We want to know how many gestational weeks is the patient, and we want to identify risk factors. We want to order laboratory testing, which we're going to discuss this more in the next videos. Order laboratory testing, and we need to schedule next visit. So the diagnosis of pregnancy, most of the time we do it with a positive beta HCG. This is the preferred method to confirm pregnancy if the last menstrual period is less than 1 week later. And normally the beta HCG becomes positive after 1 week post-conception in the serum, but most of the time the test that the pregnant woman uses to know if she's pregnant is a urine pregnancy test, which detects beta HCG in the urine. So this becomes positive about 2 weeks after conception when implantation of the placenta starts. Other way to diagnose pregnancy is using an ultrasound. When we visualize the gestational sac with an embryo, if we want to correlate the beta HCG with the ultrasound, this is when the gestational sac is seen in the ultrasound. This is about 5 to 6 weeks gestation, which corresponds to having beta HCG levels of 1,500 to 3,500 international units per milliliter. So this is called the threshold when we are going to detect a gestational sac, which is when we have this amount of beta HCG in a normal pregnancy. So if we're going to detect a gestational sac, this would be 5 to 6 weeks after 5 to 6 weeks gestation, which corresponds to having a serum beta HCG level of 1,500 up to 3,500 milliunits per milliliter. If we are going to date the pregnancy, this is we want to know how many gestational weeks is the patient. We normally we take the initial date we estimate as being the gestational date when the patient come to the visit. For example, we take the last menstrual period most of the time. But if there is a variation between last menstrual period estimation of gestational weeks with ultrasound estimation of gestational weeks, if there is a big variation, then instead of last menstrual period we use the ultrasound. And after this, or is this what we are going to use to compare to next visits? So the next evaluation of gestational weeks is going to be based on the first ultrasound or the last menstrual period. Then we can use the fundal height to evaluate for gestational weeks. This is after 20-week gestation. The fundal height correlate with the pregnancy weeks or the weeks of gestation. So if a patient is 32-week gestation, this is fundal height would be 32 centimeters. So this is a way in which we can have like a good estimation of in which gestational week the patient is, measuring fundal height if we doesn't know anything about the last menstrual period or ultrasound. But if we have polydramnios or oligodramnios, obviously this is going to change. This is going to alter fundal height independently of the gestational weeks. So, but this is something we can use as a guide to evaluate, for example, for intrauterine growth restriction. And then we are going to estimate the due date, again, based on the last menstrual period or based on an ultrasound. The first ultrasound we do, normally this is a transvaginal ultrasound. And if we are going to estimate the gestational weeks based on the transvaginal ultrasound, what we measure is the crown run length, which this gives us a plus minus 5 days accuracy of gestational age estimation. After this transvaginal ultrasound, the next ultrasound we are going to do throughout the pregnancy are transabdominal ultrasounds. The ultrasounds we do in second and third trimester. Second and third trimester are transabdominal ultrasounds. And here we measure the femoral length, the abdominal circumference, the circumference of the head, the biparietal diameter, and this is to estimate gestational age based on a transabdominal ultrasound to compare it with the initial ultrasound, which gave us an estimation of the gestational age. So this is transabdominal ultrasound. How do we estimate gestational age based on transabdominal ultrasound with femoral length, abdominal circumference of the head, and biparietal diameters. Next, we are going to identify risk factors. So here is when we take the past medical history, past historical history, obstetrician history. We need to evaluate how many times the patient has been pregnant, so gestation, how many deliveries the patient has had, full term, preterm, abortus, and live birth. We talked about this in the previous video. Sexual history, social, and the presence of teratogens. For example, if the patient is consuming some drugs or exposure to radiation, for example. And family history. Then the schedule of the visits is going to be roughly in the first trimester. We are going to schedule the next visit every 4 to 6 weeks. In the first trimester, every 4 to 6 weeks, we are going to evaluate the patient. Then in the second trimester, the visits here in the second trimester are indeed to evaluate, for example, for and upload this. So here the evaluation is more to do testing than just like a visit to see how the patient is doing, as in this case. Here the appointments are to evaluate how the patient is doing, and here in the second trimester is more we need the patient to come to have done testings. And in the third trimester, we are going to schedule visits every 2 to 3 weeks to see how the patient is doing. This is like a rough way to visualize it. Another way to schedule this is from 0 to 28 weeks gestation. We are going to schedule visits every 4 weeks. Every 4 weeks from 0 to 28 weeks gestation. From 28 to 35 week gestation, every 2 weeks we are going to schedule the patient. And after 35 weeks up to delivery is going to be every week. So this is how we schedule next visits. And now we are going to see the orders. The laboratory test we are going to order in the first visit. So first we have the hematologic testings or hematologic laboratory tests that we are going to order, which is complete blood cell count to see the normal leukocytes, to evaluate if the patient has anemia, which remember that 10 to 12 grams per deciliter of hemoglobin is normal in a pregnant woman because of the dilutional effect of the normal or the physiological changes of pregnancy. And the normal count of leukocytes is up to 16,000 leukocytes. So it's normal to have a high amount or an increased amount of leukocytes during pregnancy. Complete blood cell count. We evaluate for anemia, mean corpuscular volume. If the patient has diabetes, then we can order glucosylated hemoglobin. We want to know what is the blood type of the patient, and the Rh antigen status. This is going to be done via the Coombs test, direct Coombs test, and we also want to know if the pregnant woman has antibodies to red blood cells. So to evaluate this, we do an indirect Coombs test, which is also called atypical antibody test. Then we go to evaluation of infection disease. Evaluation of infection diseases. So we do urinalysis. Here we can evaluate for proteinuria, glucosuria, which all these give us information about the kidney. We evaluate for ketone bodies and bacteria. Also, we do a urine culture because we can have a patient with asymptomatic bacteriuria, and this is important because even though it's asymptomatic, in 8% of the patient this can progress to pyelonephritis, and in 30% of these patients this gets complicated. So asymptomatic bacteriuria in pregnancy, this is important. So we take urinary cultures. Here one of the, well, we're going to do urinary culture, but one of the bugs for which we test is group B strep. If this urine culture is positive, it doesn't matter if we treat the patient for this for this infection. At the moment of vaginal delivery, the patient needs to receive intrapartum penicillin. Independently if the patient is treated for this or no. It's an indication to receive intrapartum penicillin if a urine culture is positive for group B streptococci. Then we do testings for hepatitis B. We just order the antigen, the surface antigen, of hepatitis B. If the woman has IgM antibodies to surface antigen, this indicates that the patient has a recent infection of hepatitis B. And if this is the case, if the surface antigen becomes returns positive, then we order the complete laboratory test for hepatitis B. If the patient has had infection with hepatitis B, then she will have IgG antibodies to surface antigen, and she will also have IgG antibodies for the core antigen. What determines the risk of vertical transmission to the fetus is the surface antigen, and the envelope antigen, or the E antigen. This is a surrogate of how infectious the patient is. But what determines the vertical transmission from mother to fetus is the surface antigen. So what we care most is the surface antigen. This is the antigen with which we do screening test. If this is positive, then we order the complete hepatitis B test. In cases of high-risk population, we can also have hepatitis C test, and depending on the population status, we can evaluate for vaccination. Also varicella, we also need to evaluate for varicella vaccination. And remember that varicella and rubella vaccine, this is a live attenuated vaccine. So all live attenuated vaccines are contraindicated during pregnancy. And for that we need to evaluate if the patient has been infected with rubella, or if it is at risk of getting an infection. So we ask for antibodies for rubella. If the patient has IgG antibodies for rubella antigen, this means that the patient has had a previous infection and now she is immune. But if she has an IgM, that means she has an active infection right now. Or if we do not detect any antibody, so the patient is at risk of having rubella infection, and so after delivery we should encourage the patient to get the MMR vaccine, mumps, measles, rubella vaccine. But the vaccine is contraindicated during pregnancy because it's life attenuated. We also evaluate for infection with HIV. Now this is due to every woman. If the woman does not want to do this test, then she needs to sign a paper saying that she does not want to be tested for HIV. But otherwise, if the patient does not say anything, she is going to be tested for HIV. The screening test is with ELISA, and if this becomes positive, then the definitive test is with Western blot test. We can have a delay between when the patient is infected up to when the ELISA test is positive of 3 months. So the patient can be infected, but ELISA test can be negative until 3 months after the patient got the infection. And if the patient has HIV, then after 14 weeks gestation, she needs to start triple therapy regimen until delivery, and she should have a cesarean delivery or a C-section. We also evaluate for tuberculosis disease. So we do PPD test. If the PPD test is positive, that is when we have induration, not just erythema. Erythema, everybody is going to have erythema. But if the patient has induration, this is a positive test. If it's negative, then we do not do any further evaluation. If it is positive, then we order a chest X-ray to evaluate for active tuberculosis. If the X-ray is negative, then the patient is going to take isoniazid for 9 months with B6 supplementation. But if the chest X-ray is positive, then we go with triple drug regimen, and we are going to culture and induce sputum. We also need to evaluate for other sexual transmitted disease, as is chlamydia and Neisseria. We do this with DNA testing of the bug, and we evaluate for syphilis. The screening test is the Venereal Disease Research Laboratory Test, VDRL, or Rapid Plasma Reagent. These are non-specific tests for syphilis. If these are positive, then we need to confirm that the patient has infection, because this could be false positive. So if it is positive, then we do a specific treponemal test, which is the FDRL, which is the fluorescent antibody, and MHA. So in the initial visit, we need to diagnose that the patient is pregnant. We do this based on the last menstrual period and transvaginal ultrasound. We estimate the gestational age at the initial visit, which will be based on the last menstrual period, and with the transvaginal ultrasound, which is positive after 5 to 6 weeks. Also, the definitive diagnosis for, or the most of the time, the positive definitive diagnosis of pregnancy with the beta HCG becoming positive. We are going to date the pregnancy. We evaluate for risk factors, so that is when we take the complete history of the patient. We schedule visits and we order laboratory tests. So hematologic test, complete blood cell count, glucosylated hemoglobin in case the patient has diabetes. We need to know blood type and Rh status of the patient, and if the patient has antibodies to red blood cells, so direct and indirect Coombs test. Then infectious disease, we order urinalysis, urine culture, sexual transmitted disease, which is gonorrhea, Neisseria, chlamydia, Neisseria gonorrhea, chlamydia, syphilis, HIV, hepatitis B, hepatitis C in some cases. We also evaluate for infections with varicella, rubella, HIV testing, which is with ELISA, and the PPD test for tuberculosis.